All right, so this is lecture 2 of patient care. All right, so weighing patients. So of course we know it's important for us to weigh patients because it helps us accurately determine what type of treatments or the dosages of medication we're going to give, stuff like that. A lot of that is determined on the patient's weight. So for that reason, we need to make sure that we get accurate weights on patient, and sometimes often. If a patient has heart failure, an increase in a few pounds can be significant because remember, heart failure means that my heart isn't beating good, and if my heart is backing up with blood and fluid, that'll show in weight gain. So for a patient, if I gain 5 pounds in 3 days and I have heart failure, that tells the staff that my heart is getting worse. So we need to do something right away. So something as simple as looking at a patient's weight and heart failure can help save their life. So you may have a patient, usually patients who have heart failure, they have to get their weights daily, a daily weight. So again, an increase in just a few pounds can be significant. It's very important that you learn about the different types of scales. There are upright electronic scales, there are mechanical scales, there are bed scales, there are chair scales, there are sling scales, there's different types of scales. But we have to always make sure that whatever scale we use, that it is set to 0 beforehand. Sometimes scales may be set to different settings. Let's say, for instance, the picture you see right here is a wheelchair scale, right? And let's say that I know that my patient, her wheelchair is 15 pounds. So I can set the scale to 15. That way, when I put the patient on the scale, I already know, oh, okay, well, 15 of those pounds was the baseline. That's the wheelchair. So whatever pound I get now, I know that that's the pound, right? That's the actual pounds of the patient. Or I may zero out the scale. I may know that the wheelchair is 15 pounds, but then when I take the patient's weight, I'll subtract 15 from it because I know that 15 of those pounds was the wheelchair. So there's little things we have to do and be conscious of. If I weigh my patient every day with shoes and clothes, then I need to keep doing that. I don't today just suddenly decide to do them naked, because now those clothes could have been 2 pounds. Remember, I just told you 2 to 5 pound difference is significant for a patient with heart failure. But now that's an inaccurate reading because of the clothes. So it's not like, all patients need to be naked when you get their weight. No, because usually the scale is in a common area. So it's not going to make sense to have our patient be naked in a common area to get their weight. But just be conscious that, hey, we always weigh this patient in shoes and clothes, and so I'll make sure I do that every single time. Make sure the scale is always set to 0 and ensure that you eliminate any type of tripping hazards around the scale for patients that can walk, because they're trying to step up and, it may be uneasy for them. It's a small little space they have to stay in. They can get dizzy or trip. Always encourage your patients to use some type of safety feature. Like, for instance, some scales around them, there might be handles that they can hold on to keep themselves steady and so on. When using a mechanical scale, you start moving all the weights to the left side. So just like the scale we got in here, all the weights go to the left side, and then you get the patient on the scale and you slowly move the large one over groove by groove, and then you do the smaller one. If the patient is in a wheelchair, then you are always going to use a chair scale, and then you'll put the wheels of the patient onto the scale, and then of course subtract the weight of the wheelchair. I don't take people's words for it. Like, I'm the type of person, I'm gonna go take my wheelchair, I'm gonna put it on the scale. Okay, and then, now I know this is 12 pounds. Then I'll go and get my patient, put my patient in the wheelchair. And then I don't like going for people's words for stuff, because sometimes people get things wrong. And I wanna make sure I get it right. There are also bed scales. But remember, a bed scale could be different. So if I've got my bed scale is zeroed out, but my patient was on it, and last night they only had 1 blanket, but now today they got 3 blankets, well, that third blanket can change the weight, right? So I need to either A, be conscious that my patient has more blankets than usual, or B, get the patient out of the bed somehow and zero it, and then put the patient back in the bed, and then weigh them. So it just depends on what's going on, but seeking training on proper use of how to operate these different weighing machines is really important. You don't just want to use it and think you know what you're doing. You do definitely want to make sure you get trained on it. Make sure you subtract things like the bedding, or maybe the patient has a Holter monitor on, right? And they don't usually have it on. Something, whatever it is, you want to think about those and make sure you subtract those. Always explain to your patient what they're doing, tell them how to be safe, and then ensure that everything is connected properly, and then go ahead and weigh your patient. All right, now we're on to emotional support. I think emotional support, I feel like we don't need to go word by word through this, but the biggest thing for emotional support is empathy. Empathy is different from sympathy. How? That's what we have to ask ourselves. So sympathy means I can sympathize with you because I've experienced it, right? So let's say I was a parent, I don't know, let's say my mom's been in the nursing home before, right? So, and now your mom's getting ready to go in a nursing home. I can sympathize with how you feel because I've been there. But with empathy, it's different because I don't know what it feels like. Empathy means I don't know what it feels like, but I respect your feelings and I'm trying my best to understand them. Yeah. I may not know what it's like because I've never had to put my mom in a nursing home. I've never even had a mom. So maybe I don't know what any of that feels like, but just because I don't know what it feels like doesn't mean I can't try to understand your feelings, and that's what empathy means, okay? So often patients and their families will express anger, they'll be frustrated, they'll be mad, they'll be anxious, they may even cuss you out sometimes. Don't take it personally, it has nothing to do with you as long as you show empathy, because 9 times out of 10, you can't understand what they're going through. You just can't, because you haven't, but showing empathy is helpful. So I think that's probably the biggest takeaway from this. Let's read the question and see if we can answer it. Which of the following are indications that you are actively listening? All of these. As long as I'm smiling, I'm making eye contact, I'm sitting up straight, I'm not looking like, girl, if you don't hurry up. I'm being respectful, I'm being attentive. All of those help a person know that I'm actually listening. So here's some therapeutic communication skills. We don't want to tell them, okay, here's an example. It says the skill of accepting. So always hear what your patient has to say and then follow their thoughts, follow the thoughts that they express. So you might say to them afterwards, I get what you're saying. I understand what you're saying. And then you can repeat it back to them. What I hear you saying is, you're a little scared because mom's never been in a nursing home before, right? Explaining it back to them. Sometimes if you don't understand and you need to clarify, then you can ask them a question or say, I'm not sure that I'm following that. Can you explain for me in another way? Encouraging information. Maybe they're not talking to you, so you're trying to get them to say stuff. So you can say something like, tell me if you start to feel anxious, or tell me if you start to feel scared. That way I'm encouraging the patient, because sometimes you can see it on their face, but they're just not going to say it because they were taught maybe culturally that they're not supposed to say those things. They're supposed to take it like a man or whatever. So you can kind of say to them, it's okay to tell me if you're scared or if I'm making you feel uncomfortable. Just let me know. Exploring, a way you can encourage patients to explore is you can ask them, can you tell me a little bit more about that? You know, like, I don't want to eat. Okay, you don't want to eat. Can you tell me a little bit more about that? What's going on? Why don't you want to eat? Is it because your mouth is sore? That's why you don't want to eat? Is it because you've been having diarrhea and your stomach hurts? That's like, why? Talk to me about why. But rather than saying, why you don't want to eat? Yeah, they be like, who the hell are you talking to? I don't want to eat because I don't want to eat. You know, but it's kind of like, well, can you tell me a little bit more about what's going on? That way I can help you. And so on. So they just give you multiple ways. Sometimes if you see something in your patient, right here it says making observations. Sometimes you can ask your patient in a way, it seems to me like you seem like you're a little nervous today. Is that correct? You know, am I understanding that correctly? No, you're not? Okay, well, talk to me a little bit about what's going on there, because I see something that's different in you. Can you tell me what that is? And then reflecting is very important, because again, that's repeating back to the patient that you heard what they said. Sometimes we hear things, but we hear them wrong, right? And so if we say it back, the patient might be like, no, that's not what I was trying. That may have been what I was saying, but that's not what I was trying to say. Let me say it a different way. That happens. And then summarizing is just, hey, so just so that I understand properly, this is what we were going to do today. These are the things you agreed to do today. Are we on the same page before we move forward? Ineffective communication. Anytime you're feeling the need to tell the patient, if I were you, I would, blah, 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 that's inappropriate because it's considered advising. And we are not, as patient care techs, ever to advise our patients. If we're agreeing or disagreeing, I agree, your chemotherapy would be the best option. That's none of your business. Okay, you shouldn't tell them I agree with what you're doing or I don't think you should do that. I think you should do this instead. We don't want to do that. We can say things instead like, I see that you are a little unsure about the choice you should make. Am I correct? Okay, then let me get someone to talk to you about that, right? We don't want to tell them. Defending is something that patients may take wrong. Let's say the patient is saying something that they don't like about that doctor, and then you come back and you say, well, Mr. Lopez has been doing this for a long time. She knows what's best for you. You just need to listen, No, you should say, thank you for sharing with me that you're not feeling comfortable with Dr. Lopez. Let me get Nurse Randall so that we can find out a plan to make you feel more comfortable. Make sure that they feel like they're heard. Probing, we don't want to probe. Probing, so what did your daughter want to do today? Why is she coming here? What she say she want to do? Where's she taking you? That's you just stay out of it. That's probing, and that can be a little invasive. And then reassuring, telling a patient everything's going to be all right. We don't do that because we don't know. Everything could not be all right. And so that could be considered giving false hope. Well, you told me it was going to be all right. Exactly. So we don't want to give false hope. Boundaries are important. I can't tell you enough. Your patient does not need to know you got 6 kids, and they don't need to know that. They don't need to know that you got a second job, and this is your first one, and you got to leave so you can get to the second one. They don't need to know any of that. Anytime you feel like you're getting ready to dump a load on them about your personal life, immediately stop. That is considered inappropriate in your role as a provider to them. And sometimes it's hard because you get to know them and they tell you stuff about their family, and sometimes you feel like you want to tell them stuff too. But now, if they ask, do you have kids? Yeah, I have kids. Then I just kind of keep going. I don't go into, I got kids, I got 3, I got a girl and 2 boys, and one of them do this and the other one do that, It's not saying you don't want to answer those questions or seem standoffish. I would probably answer them and then just change the subject, as best as you can. How many kids do you have? Tell me about your kids, Be aware that you might have different viewpoints or different personal biases that may be different from your patient, especially now. There are a lot of different viewpoints. A lot of patients who are boomers, they don't believe in all this sexuality stuff that's going on. They don't believe in LGBTQ. They don't believe in man being with a man, whatever. Most of them, not all, but most of them just do not believe in those things. And that's just one example, right? Like there's I may not believe that a black woman should be with a white man. I may not, whatever their personal thoughts are or biases are, we don't reflect ours onto them, right? We can't say, well, that's wrong, or you should think of this, or I feel like this. That has nothing to do with anything. So it says avoid figurative language, like I'm all ears. Remember that nonverbal communication is important, so they can tell when you here she go again, rolling your eyes, looking away, those types of things. Try to keep the conversation straightforward and brief, but still show some compassion and listen. And then if a patient is not fluent in your language, just make sure that you're speaking the language that they speak in front of them. All right, oxygen and equipment. This is going to be a big one. Oxygen and equipment will be a big one, so let's go through this one. After surgery, some patients require supplemental oxygen. Patients who have respiratory disorders may need supplemental oxygen. Can you name 2 respiratory disorders? Uh-huh. Asthma. Thank you. One more. Pneumonia. Very good. So either situation could cause a patient to need oxygen. Oxygen is a medication. You need to know that. Oxygen is considered a medication. And I know that might be weird because it's like, well, we're breathing oxygen right now. How is that a medicine? Because you're giving the patient more than what normal people would breathe. And for that reason, it is a medication. So only a provider must prescribe the flow rate of oxygen, and only a licensed provider can actually put the oxygen on the patient. So you need to know that you are not supposed to be changing the 2 to 3 liters and doing all of that. And no, you do need to be familiar with the oxygen and what it is and how it works, but you shouldn't be putting it on or changing anything. In the hospital setting, oxygen is usually delivered through a wall system where they actually take air from the environment and condense the oxygen down to a certain amount. And then there's a little valve with a flow meter, and the patient puts the oxygen mask on and they can breathe oxygen through it. There could be also a face mask. So you see these two pictures. This is the nasal cannula where it just goes directly in the nose, and then this is the face mask. By the way, face mask is especially like for people who are mouth breathers, or they can't breathe through their nose good. That would be, and usually kids are best with masks. And then the nasal cannula for adults. But nasal cannula can be very drying to the nose because they're literally just pushing air up constantly. So people who have nasal cannulas may get bloody noses. They might need like something to moisturize their nose. So that's something to think about. When assisting a patient with oxygen, first verify with the nurse that they're supposed to have it. Explain the procedure, answer any questions about the need for oxygen, and make sure they understand safety. So oxygen safety is a thing. I can't tell you how many, when I worked at the burn unit, I can't tell you how many people would come in with their whole face blown off because they did something inappropriate with oxygen. And I'm talking about the whole skin on the face gone. So some safety things to follow for oxygen. Make sure that there is a sign on the patient's room that says oxygen in use. Any patient's room you go in, if they're on oxygen and there's not the sign, you need to tell the nurse because the sign needs to go in there. Or there may be a no smoking sign, which nobody should be smoking in the hospital anyway. But let's say you do home health and you come to somebody's house and you need to have an oxygen in use, no smoking sign, because a little bit of smoke, a little bit of lighter flick, if there's enough oxygen in the air, boom, you can just have a blow up in the air. Avoid electrical equipment like using an electric razor or heating pads when a person has oxygen on, because that too can spark a flame. And then keep oxygen cylinders away from heat sources. So those big giant oxygen cans, keep them away. Like in the wintertime, sometimes people will have those heating, like those little space heaters. Yeah, if you have an oxygen cylinder next to a space heater, it will blow up. And I'm talking about like a bomb blow up. Excuse me. Make sure the tubing doesn't have any kinks or that people can't trip over it, and make sure that you know where the fire extinguisher is in the house, just in case something does catch on fire. And most of all, nobody on oxygen should be smoking at all, period. Because you will blow your face off. Gathering supplies for oxygen. So the person may need a nasal cannula. They may need to help adjusting the tubing over their ear. Sometimes the tubing gets too tight and it will break the ear. So make sure you're looking at patients who are on oxygen. Look on the top of their ears and see if the cannula is like eating into their ear and breaking the skin. If it is, they have like little devices you can put over it to like a cushion to put over the ears to prevent it from eating into the ear, because it will eat into the ear. Place the strap over the patient's head if they're having an adjustable face mask. But again, same thing, especially right here by the ears, it usually digs into the skin. So always look around the ears for people who are on oxygen. Complications from oxygen. Oxygen can cause the patient's nasal cavity or mouth to be dry. If a patient is receiving oxygen at a flow rate of 4 liters or higher and has dryness, always attach the flow meter to a humidifier. And it's just basically water, like the little part that comes from the wall or the oxygen tank or whatever. It's like a little water device, and it blows bubbles. The little bubbles you hear, and that's bringing water into to moisturize the noise. Yep, yep. Check that the humidifier is bubbling and that the level of water doesn't get too low, because if it gets too low, you need to fill it back up again. Applying a water-soluble lubricant to the nose can be helpful, but don't use petroleum jelly. Petroleum jelly will catch on fire. That is very important to know. Never use petroleum jelly on the nose because it will catch on fire. So they said it's called like a water-soluble lubricant you can put around the nose if need be, but usually the humidified air is enough. When caring for patients on oxygen, here are some signs of hypoxia. What does hypoxia mean? Low oxygen. You need to know every last one of these right here. Low oxygen, if a patient is very anxious all of a sudden, if their face is cyanotic, remember their lips get blue, if they're having a hard time breathing, like you see them taking deep breaths and fast breaths, all of those are concerns that they may not be getting enough oxygen. Notify the nurse immediately if you do a pulse ox and it's less than 90. If the portable oxygen tank is low, that's very important. Every time when I have a patient that's on oxygen, I look at their portable tank, and if as soon as I look there, it only says like 10% left or something, then they're gonna run out of oxygen, and then what are you gonna do? So you need to call for someone to get, if my patient's on 50% and I don't have a backup cylinder, I'm calling somebody. There is a such thing as well, those are for portable ones. There are such things as the kind, like they're big giant machines and they just take oxygen from the air and create concentrated oxygen. You don't have to ever worry about those running out, but the cylinders will run out. And then any sudden changes in the patient's condition warrant you to be wondering if they're getting enough oxygen. They start sounding confused or something. Now, there is what's called suction equipment. This right here is a suction catheter. This part right here at the tip is the part that goes in their mouth. If you've been to the dentist, you've had one of these, right? They spray water in your mouth and they put the little suction thing in it and it sucks it all up. This part right here is the suction, is usually like connected to the wall or something to pull the saliva out. But you can use a suction to remove blood, mucus, vomit, any type of secretions from the mouth or in the throat. And you may be delegated to do this. They might say, hey, as you're washing the patient's mouth out, make sure you use the suction to suction any leftover gook, especially in unconscious patients. You'll do that a lot. There is a oropharyngeal suction. That basically is the throat and the nose and the mouth. They use those in surgery. So remember how I told you if you go and you get training to go to surgery, then you'll get training on something like this because you'll be using that in surgery, but maybe not the ED, right? It just depends on where you go work. Explain the procedure to the patient and warn them that suctioning them could cause them to cough. It could cause them to gag. It may even cause them to sneeze, but they need to be prepared because they're not going to be able to get it out themselves. Again, the head of the bed needs to be high, or if they're unconscious, they do what? On the side, laterally. Very good. Connect the suction catheter to the suction, and you always test the suction by maybe sticking the tip into like a little bit of normal saline to see if it sucks it up, and if it sucks it up, you know it's working, and then you can start using it on the patient. Glide the catheter around the mouth until you remove all secretions. This is important, but for no more than 15 seconds at a time. The suction should not be in the mouth for no more than 15 seconds at a time. So every 15 seconds, pull it out, give the patient a chance to breathe or whatever they need to do, and then you can reintroduce the suction catheter. This is a good example of something that you may not have seen anywhere yet. It wasn't in a book. It wasn't in your course, but NHA wants you to know this. 15 seconds at a time. Clean or discard the catheter after each use. You might have to get a new one. Usually they're good for about 24 hours. When caring for a patient who has a tracheostomy, what is a tracheostomy? Any ideas? A tracheostomy is a hole right here in the neck. They get a little hole in the neck, and then they have to breathe through that or whatever. That's a tracheostomy. You may. Yep. If you're on a unit where a patient was unconscious for so long, you can't keep the tube down their throat but for a week or two. So if I don't wake up out of a coma after 2 weeks, they put a hole in your throat and stick the tube down there instead to help you breathe. Yep. But anyway, if you have a patient who has a tracheostomy, where was I at? Okay. Position the patient for suctioning. And again, as I mentioned, most patients who have trachs are going to be unconscious. Some of them could be conscious. But either way, you may want to give them like a piece of paper and pen to write with to talk to you, because people who have trachs, they can't talk. It's bypassing their vocal cords. Our vocal cords are up here. And so the hole right there is bypassing your vocal cords. They can't talk. So always give them a piece of paper and a pad so that they feel like they can communicate with you if they're telling you that it hurts or whatever. Sometimes people give them like a little board where they can point to something, pain, or I need to spit or whatever. And then you gather all your supplies and you'll suction them if you need to. Again, you can test the catheter by sticking it in saline. Let's see. Okay, this is something you should know. If you have to suction a patient who has a tracheostomy, you only advance the catheter into their trachea until you feel resistance, and then pull back the catheter 1 centimeter. So remember how I said we would stick the catheter down their mouth to suction them? Mm-hmm. People who have trachs, you stick it down there, because now that part is their mouth. You stick the suction down the trach until it doesn't move anymore. And then you pull it back. Then you pull it back 1 centimeter, and then you start suctioning.
And you don't leave that for longer than 10 seconds.
Exactly. Do not suction for longer than 15 seconds. Very good. Okay. In the hospital setting, you're always going to hear like monitors and alarms going off. They've got the cardiac monitor, which goes on the wall, and it does the heart rate and the heart rhythm. Remember the ones that we said had the 5 little things on the chest? Mm-hmm. And then you have ventilators. So a ventilator is a machine that makes me breathe. It's like an artificial lung. I can't breathe for myself, so it breathes for me. You have your capnography monitor, which this measures carbon dioxide exhaled. So each time the patient breathes out, it measures how much carbon dioxide they're breathing out. You have a continuous pulse ox. That's the little monitor I'll show you guys we put on our fingers. Mm-hmm. They have continuous ones. It looks like tape, and it just tapes to the tip of the finger, and it stays on there for 24 hours a day and monitors that. And then we also have infusion pumps. So this delivers medication directly into their IV port. So imagine having a patient that has all these, right? They got a tube everywhere, a tube on their heart, tube on the down their throat, tube on their finger, a tube in the IV, like everywhere. You have to be super careful with these patients when you're caring for them, giving them baths, turning them, all that stuff. And there's somebody who's responsible for monitoring all these things. You don't have to monitor them, but what you do need to be paying attention to is if one of them's disconnected, right? Like if I'm in here and I don't see that their finger is connected to the continuous pulse ox and they were yesterday, I need to ask somebody, why is that not connected? Because it probably should be. All right, beds. There are different types of beds in the hospital setting. We have bariatric beds. What does bariatric mean? Bariatric is, in healthcare, we might say big. Some people will inappropriately say fat, okay? But we use the word bariatric. It just means the person is larger or they're obese, exactly. And so because of that, they need a bigger bed than most people would need. Then you have alternating pressure beds where it's kind of like an air mattress, but it pumps up and then it goes down, and it pumps up on the left and goes down, pumps up on the right and goes down. Why do you think we have an alternating pressure bed?
To help maybe the patient who is bedbound, so moving around so they won't get any
Pressure ulcers, that's right. Yep, exactly. It kind of distributes the weight, because when you're laying in bed, you usually turn side to side, right, without even thinking about it. But if I'm immobile, I can't. And so this does that for me to distribute, like you just said, distribute the weight so I don't get a pressure ulcer. I love those beds too, by the way. Then you have an airflow bed where it says there's The patient is on a fabric layer containing small beads, and they constantly circulate on the patient. It's kind of like a constant massage. Mm-hmm. Yep, and this also prevents pressure ulcers on the skin, and it helps the blood circulate and flow. Yep. And then you have a pulmonary therapy bed. Pulmonary therapy, pulmonary means what? Lungs. Okay? So this is a bed that vibrates in the back of the chest, and it vibrates and like breaks up any type of pus or anything sitting in the lungs. And then it helps the patient breathe, and it also helps relieve pressure ulcers. It does a lot. They're really cool to see too. The patients don't like them because it kind of, it's like a beating in the back, but it's good for their lungs, very good for their lungs. So those are some different types of beds you might see. Again, if I have a bariatric bed, then I need to get bariatric sheets, right? That's why it's important for me to pay attention to these things. I come into my patient's room with regular sheets and they got a bariatric bed. I just wasted sheets and I wasted my time. So make sure you're paying attention to that stuff. Feeding tubes. Is it almost time? Yeah, it is. Yeah, okay. Let me do feeding tubes and I'll stop. Okay. Some patients have difficulties chewing or swallowing, and they may need to have a feeding tube because of that. So sometimes they refer to it as inaural feedings. Inaural just means it enters the body outside of the mouth. Okay, so it went into the body, but not through the mouth. It can be liquid formulas. They usually may go in a nasogastric tube. Naso means it goes down the nose, and then gastric means the stomach. So it goes from the nose into the stomach. Or you may have a feeding tube that's just temporary. It just is a hole in the stomach. In the abdomen, it goes straight into the stomach. Those are called gastrostomy tubes or jugostomy tubes. That just, gastro is the stomach. Jugostomy means the small intestine. So it's what part of the gastric system it connects to. But anyway, these are surgically placed by a doctor. And then it's permanent. It's a little bit more permanent. And then so if I am never going to be able to swallow again, I might have to live off of liquid food for the rest of my life. I need a permanent tube for someone to constantly feed me. So nurses usually give these feedings. As a patient care tech, you may not, but you may still need to know and observe because let's say I just ate, right? After I just ate, my head should be high at least an hour after I eat, right? So let's say the nurse came in and fed me, and then you came in to change my bed, and you lay me flat 10 minutes later. You lay me flat and you move me around and you try and change my bed, I could throw up, right? And if I throw up, then I'm going to possibly what? Aspirate. And then I can get pneumonia, right? So it's like a whole cycle. So we have to realize like, oh, this patient just got a feeding tube. I better let them sit up for a good hour before I start laying them flat and moving them around and doing stuff to them. So it's important to know when a patient has had their tube feeding so you can be conscious of that. Lying a patient flat increases their risk for aspiration. There is a such thing as continuous feeding too, by the way. Some patients just get continuous feeding all day long. It's just a small amount. They just put a small amount. It's like a machine, and it just enters a small amount into their stomach all day long. Those patients have to have the head of the bed up all day long, right? And the only time you can move them in a flat position is if you talk to the nurse first, and the nurse pauses the continuous feeding. And usually even we pause it, we wait 30 minutes, and then we'll lay them flat, put the patient back, and then go tell the nurse, hey, I'm all done. You could turn the tube feeding back on. The patient care tech should never be stopping and should never be starting the tube feeding, okay? Also look around the skin where the tube is inserted. Sometimes the skin will break down because the tube feeding will ooze out and get on the skin. So you'll be, when you're bathing the patient, you'll be looking at that hole to make sure it's not getting irritated or it's not getting swollen or smelling funny or something like that, because you need to let the nurse know. All right, let's read the question and then I'll let you go. When a patient is receiving continuous inaural feedings, at what degree of elevation should you keep the head of the bed? C, it's always 45. Very good. Head of the bed should always be 45. If they're laying flat, that's not good, and it could cause aspiration. All right.